I don't think there's a topic that we see more often where the story is people come to us for a second opinion. They were told, I don't need hormones, hormones aren't for me, my numbers are fine, your symptoms are not related to hormones. I mean, it's all the time. And we just, I mean, every day we're having patients come to us kind of with that story, unfortunately. But also in the same day, we're having a lot of patients who, when they sit down, and my question to them is, how are you feeling? Oh, I feel great. Or guys are, guys and, males and females are like, I feel like I'm in my 20s again.
Yeah.
I feel like, I haven't felt this good in forever. I mean,
I didn't know this was possible.
Absolutely.
Ever. Even at my height, I didn't know I could feel like this. All right. Welcome back to the True Body Podcast. We're going to be talking about one of my favorite topics, which is HRT. Basically what patients need to know and maybe what they get wrong. So I know we both are super passionate about this topic, maybe partially because we've seen such a huge impact in our patients with just kind of optimizing things just even subtly. And so we'll kind of dive into maybe each hormone, kind of what they do. We'll probably give some stories along the way and kind of go from there. But I think the biggest thing is the patients who come in and we end up going this route are literally just feeling off. They have no energy. They have brain fog. They're gaining weight. It's not like the simple, the most common symptoms of hot flashes and night sweats and the things you would think of for hormones. So, but yeah, I think teasing some misconceptions about this isn't just for menopause.
Absolutely. I don't think there's a topic that we see more often where the story is people come to us for a second opinion. They were told, I don't need hormones, hormones aren't for me, my numbers are fine, your symptoms are not related to hormones. I mean, it's all the time. And we just, I mean, every day we're having patients come to us kind of with that story, unfortunately. But also in the same day, we're having a lot of patients who, when they sit down, and my question to them is, how are you feeling? Oh, I feel great. Or guys are, guys and, males and females are like, I feel like I'm in my 20s again.
Yeah.
I feel like, I haven't felt this good in forever. I mean,
I didn't know this was possible.
Absolutely.
Ever. Even at my height, I didn't know I could feel like this.
So again, I don't know. It's just it's a broad topic. The HRT umbrella is very broad, and there's a lot of things that we hear are correct and incorrect, and unfortunately, so I think just kind of explaining it in some details, why hormones are important, how they impact so many different areas around the body, mental and physical health, and just how we approach it. Hormones in general, whether that's replacement or optimizing your body's natural production or both. Everybody's a little bit different. Definitely not a one size fits all. Not in too many areas of medicine, but definitely not when it comes to hormones, which is I think part of the reason why we both like it so much.
I think one of the biggest things to maybe start with is what is HRT? Everyone's like, oh, I'm on HRT, or have you considered HRT? And for somebody, they might not have any idea of what is HRT? Why would you come and talk to somebody about HRT, hormone replacement therapy?
Simple definition would be, we are replacing the hormones that your body is no longer able to make or able to make in optimal levels. But we are using your body's exact hormones, bioidentical. I mean, it's It's what you have. It's what I have. We are giving your body those hormones. We're not doing synthetic hormones. It's not, birth control or anything like
Mm-hmm.
that, which is
Mm-hmm.
unfortunately a common
Misnomer.
misconception, I guess. But that would be the simple definition: is we are replacing your body's
Yeah.
hormones.
And the most common ones being estrogen, progesterone, testosterone. We, occasionally talk about thyroid and we kind of lump that in, especially when we're just like evaluating someone's levels. Um, but yeah, I think usually when a patient comes to us, specifically a female, they're like, I just need to look at my estrogen.
Mm-hmm.
That's
Mm-hmm.
kind of like what we know is true. And for men, it's I just need to look at my testosterone.
Mm-hmm.
And not really thinking about all the other pieces with that and what that looks like. I think another big thing is they have no idea that there's more than one option
Mm-hmm.
of a form of getting those things in. Um, when I'm like, okay, well, we've got, you can do this estrogen in a pill, you can do it in a cream, you can do it in a patch, you can do it in a pellet. They're
Mm-hmm.
like, holy smokes, wait a second.
Mm-hmm.
What's the best
It's a
one?
lot of information.
What's the best one?
Just
And it's
that
like,
right
well,
there. Yeah.
right. Yeah.
Yeah.
It's like, well, there's maybe a lot of really best ones. I
Mm-hmm.
don't know. There's not like one more superior than another. There's some that have other risk factors associated with them. There's, compliance issues with patches, creams. There's transference issues. There's a lot of different
Mm-hmm.
things. And so it's really just, it's not like we'll ever force a patient to do one particular form. It's more of like what form works for you.
Mm-hmm.
I've got gentlemen who do 2 different forms throughout the year. They do their testosterone in an injection, and then come hunting season, they do pellets to get them through because they're in the mountains.
Mm-hmm.
So it really is just like leveling with the patient and trying to decide like what's going to be best
Absolutely.
for them.
Absolutely.
But yeah,
Mm-hmm.
there's a lot, not in just like the type, but then the form of it and the candidacy of it and all that. But just kind of goes back to your point. Like there's not a one size fits all, and there's not even just like a one season fits all.
Mm-hmm. Yep. Yeah. When I'm talking with somebody, we'll just talk about testosterone. I guess before even asking them, what do you want to do? Try to give them all the information, or as best as we can.
Mm-hmm.
Like you're talking about creams, yeah, compliance, maybe be a little bit issue. Whereas on the opposite, pellets are easier.
Mm-hmm.
It's a quick little procedure, but it's in there. You don't have to worry about it. To somebody that might sound great. To another person that might not sound
That might freak them out.
like a great option at all.
Yeah.
So I think just kind of laying out the different options, and then allowing them to whether ask further questions about that, but just simply trying to give them the information to make the decision for themselves of what
Mm-hmm.
would fit their lifestyle, schedule, just daily habits.
Yeah.
I guess, yeah.
I think the other thing too is like when patients come in, they're like, I want to focus on my energy.
Mm-hmm.
And it's like, okay, well, there's not just one hormone that's going to focus. Like they all overlap. And I think that's like another big thing is there's not just like, if we optimize one hormone, you're also going to have problems, right? We have to
Absolutely.
like make
Mm-hmm.
sure there's not I usually say this to my patients, a queen of the castle or a king of the castle. Like we need everybody to have checks and balances, and nobody can be, ruling the world. Everybody has to like work together. Because yeah, you're gonna get things. People come to us literally, we optimize their hormones, but they might come to us with like an estrogen dominance
Mm-hmm.
issue or like a
Mm-hmm.
dominant hormone that we don't necessarily want to suppress, but we
Yeah.
got to make sure it works for
Yeah.
everything else.
Absolutely. Yeah, just estrogen, progesterone alone. Seeing 2 females with 2 very different treatment plans for both of those hormones.
Mm.
Yes, we want to optimize both of them, but we might be doing completely different things.
Mm-hmm.
So there's definitely not a, you're coming to us, you're going to get this and that. It's going to be, a very detailed approach about, usually they're coming to us because of symptoms.
Mm-hmm.
What symptoms, are we having? Yes, we'll look at levels and kind of where somebody is at. What we're doing with a 20-year-old is going to be different than a 60-year-old or 40-year-old. So really just trying to get their whole history, know exactly what's going on, what their goals are, and developing a very individualized treatment plan
Yeah.
for that patient. So again, there's only, we're typically talking about estrogen, progesterone, testosterone. It's only three. In males, we're usually not talking about progesterone, but only three hormones, but a variety of different ways we can go about it. I mean,
100%.
it is very, very, it's all over the map of what we're doing with our different patients, which is exciting. It's fun.
Yeah.
It's critical thinking. That's why we got into medicine. Yeah, no, it's just an exciting, just an exciting field topic.
And in the fact that like everybody's a challenge, which I think is like super fun in some ways, because like we have the studies that kind of like indicate, what levels on average, you'll feel like, the energy, the endurance, the motivation, the libido, or, the hair, the skin, the nail changes, or, what levels are going to protect you, from Alzheimer's and cardiovascular risk and osteoporosis. We have like the studies and the data that suggest those things for females and males and kind of whatever we're looking at. But at the end of the day, everybody needs a different level. We can give you what the averages are, but you might need to be extremely below average, and that's like your sweet spot, or way above it.
Yeah.
And a lot of times those levels are not on the labs, right?
That's a good point.
The labs are going to look like you're going to come back and you're going to feel like $1 million. And the first thing we're doing is we're going to pull up your levels and you're like, oh no, those are red.
Yeah.
Either low or high. And you're like, oh, I've like overshot. And the conversation is like, you're actually great, right? You're actually in a great range and you feel like $1 million. I always find it fun to ask them how they're feeling first. A lot of times they kind of have like some push. They're like, well, what do my levels say?
Yeah.
What do my levels say?
Took the words
like,
out of
no,
my
no,
mouth. Yeah.
What? How do you feel? How do you feel? And usually like, okay, well, I guess if I can't look at my levels first, I feel great, And so then we open the levels, and they might be red, or they might be, within range, and it's that whole like, we're not chasing a number. We're not chasing a number. We're chasing your symptoms for you.
No, I'm glad you said that. I approach it the same way. Just because we've both been in the traditional primary care where usually you're walking in and you're saying, hey, here's what your levels look like, here's what we're going to do, or here's what you're going to do, and it's pretty quick and easy. But I mean, I try to get in the habit of, I don't want to look at those levels right away. I want to sit down, ask them how they're feeling, and you're right, it catches them off guard. It's like, well, what do you mean?
Right.
Like, how are you feeling?
Yeah.
How are you feeling today? A month ago, 3 months ago? And when we get that, when we find out how they're doing, we'll compare it to the labs, and if we need to adjust up, down, or stay where we're at, then we'll go from there. But, I mean, it's symptoms and then levels is how I approach it, and obviously how you do as well.
I think it's like it's just ingrained in us. Like when you go to the doctor, the first thing you talk about is like your labs.
Yeah.
Like you just go through your levels and they're like, oh, your kidneys don't look good. Oh, your blood sugar's kind of high.
Yeah.
Oh,
It's easy.
cholesterol's not great.
Yeah.
And now we're going to do a medication for that and a medication for that and a medication for that. Sometimes there's some lifestyle recommendations and things like that, which is great. But like we're treating the number. We're not treating the person. We sometimes forget that like the person's even there.
Yeah.
We're just like, oh, this is red and we need to like, what are we going to do? And what drug is going to be the best. And so it's, as the patient, you're just kind of used to that. You're just kind of used to like, that's like how we start the conversation of what's wrong with me. And a lot of my patients will also just be like, so everything looks good. Like I don't have like cancer or anything. And you're like, holy smokes. Like if we're going off these levels, if you, do you feel good? You know, it's so interesting how we just think that like all these like numbers are just going to give us this deep dive into your health when you haven't even told us like how you feel or like what's even going on with you. It's a huge piece of the puzzle.
Yeah, I think not to get too deep in the weeds, I guess, but I wish we could just eliminate the reference range on all our labs.
Oh yeah.
I mean, and to be completely honest, the conference I attended a couple months ago, or was that a few weeks ago? taught me about the reference ranges, how they're developed. It is a population reference range, meaning, the the majority of our population is falling in that reference range.
Mm-hmm.
But if the majority of our population, their levels aren't optimized,
They're unhealthy.
their
Obese.
lipid panels aren't great. I mean, if that's how we're determining what our levels should be at, I think that's
Mm-hmm.
completely incorrect. So I wish we could
Yeah.
just, and unfortunately, people want to look at those. They want to see where
Mm-hmm.
they're at in relation to the ranges.
Mm-hmm.
But again, if we're looking at averages based off of a population that unfortunately is not healthy,
Uh-huh.
a sick population, yeah, of course our numbers are going to be in the red
Mm-hmm.
because they're going to be a lot better,
Mm-hmm.
higher
Right.
typically. So I think again, it's just need to retrain how we
Mm-hmm.
look at labs, how we're looking at these levels. And again, there's no best level
Mm-hmm.
we need to be at. There's
Right.
probably a ballpark we want to get to, but
Mm-hmm.
what is great for somebody will be too high or too low for the next person. So that's where the kind of the individual component is important to look at.
Right. I usually tell patients like, don't even look over here.
Mm-hmm.
Don't even look at this side of the lab form, because it's going to give you probably anxiety or kind of like a misinterpretation of where you should be.
It's going to question what we're doing,
Yeah.
or it's going to make
Yeah.
them kind of second guess.
Absolutely.
Yeah.
And it's crazy because they're like feeling so good, but they're like, oh my gosh, should I go back to where? Should I stop?
It's a big
It's like,
bright
well, you
red
came here for a
number.
reason.
Yeah.
You came here.
Yeah.
Something wasn't great.
Mm-hmm.
But yeah, I think that's like that's like my favorite thing is to go through their levels and give them the averages or ideals for like gender and all the different things and really like open their eyes to like,
Because they're literally, they're
oh,
like,
I don't need
yeah.
to be within that range.
Mhm.
I don't have to be within that range. Giving
Absolutely.
them permission to like live on the edge, like it's
Mhm.
okay. It's all right.
Like the red numbers are not always bad.
Yeah, exactly. In fact,
Yeah.
like give yourself a pat on the back. You're there and
Yeah.
you feel amazing and like look what you've accomplished at that range. But I think, yeah, like so not only, you go through their levels and all those things, but then you're talking to them not always just about like your hot flashes and your night sweats and things like that, but you're diving into like how's your metabolism?
Mhm.
How is your sleep? How is your brain fog and your mood? How's your libido? Just kind of things that you don't normally think of, like your provider doesn't usually ask you about. I don't know the last time someone maybe went to their traditional provider and was like, hey, I'm tired. And they were like, oh, well, maybe we should do a sleep study. Maybe we should, I don't know. Where should we start here?
Mhm.
Here's here's an ambient,
Yeah.
There's like not a lot of like workup sometimes or thought of like where to even start with like that broad of a symptom. And simply just like evaluating someone's hormones and making sure they're optimized can just like cure that,
Mhm.
may not be perfect. There might be other external things you got to work through too, but
Mhm.
it's incredible like the symptoms that patients don't think are associated.
Yeah. Absolutely. I guess if somebody was going to ask you, like, who is in females, like, when can I start HRT? Because I mean, traditionally it's menopause, and then maybe we'll do something. Maybe
Right.
we'll do something. But see a lot of people in their 20s and 30s and 40s who we're talking about hormones.
Yeah.
It's a different conversation than somebody who is postmenopausal. But the same hormones, we're talking about.
Even young girls with like irregular cycles, heavy cycles, PCOS symptoms.
It's not
Yeah.
normal.
Yeah.
It shouldn't be normal.
Right.
Is there an age where we start talking about it? Absolutely not. Shouldn't be.
There's not an age that we stop talking about it
yeah.
either.
Well, same thing for guys too. The conversation might be different at 25, 30, 35 even, compared to somebody who's 50 or 60. But again, we're talking about the same hormone, usually testosterone. Estrogen too is also important. But is somebody too young to talk about hormones? Absolutely not.
No.
And again, we need to weigh who might be a good candidate for replacement versus, hey, your body's still making it. Can we just
Support it.
really support it? And we can do a number of different things. Very easy things actually that things that are not being talked about in the traditional
that's
sense.
a good point. It's not always
Unfortunately,
a pill or an actual hormone that we're like giving somebody when we're optimizing levels. Absolutely.
So I think my kind of key takeaway, or what I try to educate people on, is age doesn't matter. What symptoms are we having? What do we want to improve? What are our health goals? And based off of their answer and potentially age, and I mean, there's a lot of factors that will just kind of determine where that conversation goes. But I don't think you don't need to. There's no rules we need to follow, I guess, in terms of you're too young to talk about this or too young to talk about. I disagree with that 100%.
Yeah, and I think there's also like a lot of education in like my perimenopausal females, which is usually around your mid to late 30s.
Yeah.
You're starting perimenopause. That they're like, God, I don't know. Am I like old enough to do this? Am I old enough to like start on this stuff? Obviously, like there's checks and balances. We're looking at your labs. We're evaluating your symptoms to determine if it is or isn't. And not always is that an actual hormone. Sometimes it's, supplements, lifestyle, like different things that we're using to support it. But I think what's really important for women to understand is when you start losing those hormones, you're putting yourself at risk, and it's compounding for cardiovascular disease and osteoporosis and Alzheimer's. And so cognitive function and all those things that start to slip just subtly when you're younger, like that eventually gets worse and worse and worse. And when you come in and see me at like 42 and we initiate some sort of therapy, it is so much easier for me to prevent something then than it is when you are 52.
Absolutely.
And so, the women who've had the hysterectomies prematurely and in their 30s and, you still have an ovary, so we don't need to talk about, hormones, or maybe they don't, but it's like, oh, you only had hot flashes for a couple of weeks after that. Okay. You're not really a good candidate. And it's like, man, what are we putting that person at risk for that they have no idea until it's too late? I mean, we know based off studies that estrogen is like the number one preventative thing for osteoporosis. And yet it's the last thing we talk about.
I mean,
It's the last thing we talk about.
somebody does a DEXA, osteopenia, osteoporosis. Here's vitamin D, here's calcium, Fosamax. We'll check it again in 2 years. How about we actually look at why do they have osteoporosis? Oh, they lost estrogen. Okay, well,
Let's fix it.
pretty straightforward.
Yeah.
But no, it's medication, vitamin D, calcium, which again are important.
Right.
We need them. A lot of people who are low in vitamin D, certainly, but osteoporosis, I mean, how often do we see it, or how often do you hear about it? Somebody who was healthy, they trip, they fall, broken hip, pneumonia, they're not getting out of the hospital.
Yeah.
I mean, the difference,
sense.
it's just, I don't know, sad.
And it's, for something super like preventable.
Yeah.
And the same thing with your heart. I mean, you can look at the graphs and it's like as soon as women hit, 50 on average, that's when most women go through menopause, 51, 52 years of age. And cardiovascular risk like just starts to climb drastically.
Yeah.
And it's directly correlated to, estrogen and whatnot. And there's obviously other things. We're not definitely going to sit here and say that that's like the only thing that's going to prevent you from having a stroke or heart attack.
Yeah. Ignore,
But
absolutely.
holy smokes, if we know it's a direct correlation, well, why wouldn't we be talking about it? Why wouldn't your cardiologist be talking about it? Why wouldn't your primary care doctor be talking about it? Everyone knows about statins right now, but does anybody know about those statistics of estrogen? No, they don't.
Estrogen on its own, plus if we're combining that with testosterone, I mean, bone density improves that much more. I mean, go down the list of symptoms, just symptoms alone, not even talking about the prevention, the heart disease, Alzheimer's, bone density, all the, kind of metabolic dysfunction, all of those are going to improve, or the risk
Mm-hmm.
for developing those will go down. But again, yeah, it's
Mm-hmm.
just not something we're talking about,
Mm-mm.
unfortunately.
I think most women don't realize they should be on testosterone.
Mm-hmm.
They're like, that's a dude thing. I
Mm-hmm.
don't need that. Why would I need that? And it's like, holy smokes. I mean, the ability to just, and most women who've hit the 45 and older probably realize like how hard it is to gain muscle
Yeah.
in the gym. Just, I mean, you could eat the best and you can do the heaviest of lifts and you can do those things, but to like physically even see in the mirror like a change is tough.
Mm-hmm.
That is so tough. Even to like lose the weight doing those things is super tough. And just replacing like a smidgen of
Yeah.
testosterone
Yeah.
can make a world of difference and
Yeah.
allow you to, actually like lose, that visceral fat, around your organs and remove that fatty liver and gain that muscle and help your bones. And you feel good. You
Absolutely.
feel like you want to. You have that confidence and that motivation and the energy and the stamina back.
Mm-hmm. Mm-hmm.
It's
Yeah.
huge.
The education part of it is so important. I mean, yeah. Again, it's not a male hormone. It is. There is more in males, certainly, but
Mm-hmm.
how it impacts, a male's health, female's health, it's the same. I mean, it's
Yeah.
having the same, going down the same pathways in both males and females, and having those positive outcomes, both now, but also the long term outcomes,
Mm-hmm.
certainly. I mean, it's kind of funny we were talking about the reference range earlier, and if you look at on a female's labs, it'll say normal 0 to, whatever, 30. It's like, is 0 normal? Not. But when we're looking at a population where it unfortunately is, or it gets
Yeah.
treated as normal, yeah, it's going to,
Yeah.
of course, look like that in the reference
Mm-hmm.
range. We're starting somebody on testosterone, a female, and then we get their labs, and then, yeah, they're a little high according to that range, but they feel great.
Mm-hmm.
They feel really good. And it turns out, hey, we do very well when we actually optimize those levels, both males and females. So again, education is a big part,
And I
big
think
part of what we do.
it's important to know too, like, we're not just trying to like get your levels as high as we can.
Mm-hmm.
And, a lot of people are going to feel like $1,000,000 with like extremely high levels of testosterone. Some people won't, but that's not necessarily the goal either, right? Like within safe ranges, like we're monitoring these patients, we're making sure, blood pressure is controlled, hematocrit ranges are
Absolutely.
within check.
Mm-hmm.
Like things are no adverse side effects. They're not experiencing like acne or hair thinning or whatever the case is. And everyone, like we were saying in the beginning, is so individual on that,
Mm-hmm.
yeah, it's not a one size fits all, but looking at those reference ranges can be arbitrary in the whole scheme of things because of so many different factors.
Absolutely.
One of the biggest, I would say, questions I get from men is, if I start testosterone, will I have to be on it for the rest of my life? Will I be able to stop it? What do you usually say?
What I tell them is that when we start giving your body testosterone, it will turn down your own production. That is normal. Our brain recognizes it. Our body recognizes it. Says, hey, we are getting it. We do not need to be on, or we do not need to be making it. It's going to turn that off. So if we're basing it off of that, do we need to be on it for life? Not necessarily. If we stop it, your body will recover. It's going to go back to the levels that we were at. It maybe, before starting testosterone. But the reason we're typically starting it is because we're having symptoms, or variety of different symptoms. But yeah, they're coming to us and they are concerned because we're having these symptoms. We check levels. Yep, they're low. We're going to start it. They start to feel really good. And those are the people that are coming back and saying, hey, I haven't felt this good in years or ever. They probably don't want to stop. Number two, if we're talking about all the positive benefits long term, reducing risk of all these different chronic diseases, why would we want to stop? So that's kind of how I approach it. It gets a little bit little bit different discussion. Maybe if somebody's younger and, we're talking about, fertility and family and this and that, just a little bit different discussion. But that's kind of the two talking points I emphasize. Like we're probably going to be feeling a lot better, but then also we're trying to prevent all these different negative health outcomes. So yeah, usually we never really want to stop. Is typically my discussion.
Right. I think that's the key. Is like, why are we having this conversation?
Yeah. Like they came to us for a reason.
Yeah.
Yeah.
And the other thing too is like when we start losing our hormones, it is linear. Whether it's like a sharp cliff linear or very gradual, decline linear. So if you were to start it and 5 years pass and come off of it, yeah, you'll go back to producing what you were, but that linear decline is going to catch up.
Yes.
So you'll go back to whatever your body's capable of making at that moment, at that time, where you're at. And I think that's just like, that's just science. That's just us. But yeah, I mean, you'll go back, but gosh, if you feel this way now, oof, can you imagine 5 years down the road,
Absolutely.
And so, yeah, I think, yeah, you can come off of any hormones whenever you wish. Nothing's a life sentence. Nothing is permanent. Nothing needs to be forever. And some people do and just need to like try it and see like, is this for them or is this not? And do that whole thing. But yeah, I think, if you're that worried about it, maybe wait. Maybe wait.
Yeah.
If it's gonna be in your head. But yeah, I truly think you may not want to.
I mean, when I'm seeing somebody for the first time and we're talking about HRT, it's a lot of information in a short amount of time. We spend a lot of time with them, but it's a lot of information packed into that time. So I tell people, hey, this is not something we need to decide today. You can absolutely think about it. You can message me, get more, questions out, or just think about it.
It's information.
Yeah.
It's like, these are your labs. We just reviewed your symptoms. I'm going to help you correlate with those things. Go home.
Yeah.
Like take this information and marinate with it for a second. And maybe that's all you need to do. Maybe you come back in 3 years and that's when you're ready.
Yeah.
There's really no pressure. It's just education is power. And the more you know about yourself, the better.
Yeah. Because I can almost guarantee that the labs we're checking, the discussion we're going to have about those labs and about your symptoms is more information than you've probably gotten in the years and years and years of, previous appointments. So yeah, it's going to be overwhelming, which we try to, make it as easy as we can.
Yeah.
But I don't think we'd be doing our job if we don't give all the information.
What about the men who come and say, doesn't testosterone cause prostate cancer?
No. The study there was a study. I don't even remember. Was it 100 years ago?
Yeah.
I was looking at it a little while ago. The study was completely invalid. There was only a few people, I believe.
It was like two.
And
two
it was
patients.
like
and one
three and one dropped out or something like that. But in the years, decades of research and decades of HRT, there's no correlation between testosterone replacement and prostate cancer. And I believe the opposite is true. It is protective.
It is.
Not only against that, but a variety of other chronic diseases that we are trying to prevent. So yeah, unfortunately, one kind of completely invalid study for whatever reason has just, I don't know.
Yeah,
it's just been carried on for so long. Unfortunately,
same with the Women's Health Initiative, the 2002 study that came out, and basically before the study was even commenced, right, was on the New York Times. Estrogen causes breast cancer, and since then, I feel like that was one of the biggest reasons why providers stopped prescribing it. Right, they were scared.
Yeah.
Patients who read the study called out their providers like, how dare you put me on these medications when you knew? No one cared to look into the study further though. They just took that as gospel, which we're really good at. We're really good at listening to influencers,
Oh yeah.
listening to some Joe Schmo who saw something somewhere and now he's stating it and it's his opinion is fact. Um, and we're not super great about doing our own research
Mm-hmm.
on things. And so yeah, for forever, like my mom, my mom's mom, like people like that have, gone their whole life without being, given the opportunity of hormones. And what a disservice.
Yeah.
Holy cow.
Yeah.
The things that could have been prevented, the quality of life
Mm-hmm.
that could have been improved. It's just, it kind of breaks your heart when
Yeah.
you really think about all that.
Yeah.
And it stinks because there's a stigma about hormones, even with providers, still with hormones, and just how they're afraid to prescribe them and
Mm-hmm.
afraid to do those things.
Mm-hmm.
And so that to me is one of the biggest reasons why I love educating about it and really like debunking those things, because like we know it's not true and we can prove it.
How many SSRIs and other meds have
Mhm.
been prescribed because of 50-year-olds coming in with brain fog, they're not sleeping, and their mood's all over the
Anxiety.
place?
Yeah. Yeah.
I mean, dear God,
Mhm.
it's sad.
Yeah.
It's sad. I don't know. There's no other way to put it, but
Right.
I don't know. Hopefully we're turning the page and
I think people are talking about it more, which is great.
absolutely.
And there's like this huge movement that I think is happening, and it's really allowing people to feel more comfortable asking their providers about it. And I think
Mm-hmm.
providers who aren't even necessarily educated or trained in hormones are kind of being forced to look into things that they haven't before, which I think is great.
Yeah.
I will say there's definitely something to going to a provider who's trained in it. I will personally tell you, before I did any of my training in hormones, and a patient would come in and be like, "Hey, I want my hormones checked." I'd be like, "Okay, great. Let me Google what
Yeah.
I
Now
should
what?
run on you." And then when I got the results back, I was like, "I don't even know what to do with this. Like everything's within
Like,
range,
it
but
looks
they're
okay.
not feeling
It looks
great,
okay. Yeah.
So yeah, it's like, how do I even talk to this person about something? I got maybe a week's worth of education in school on menopause and hormones.
All the negatives,
Everything
but
bad, everything bad
not how
about
to,
them. Yes,
approach it.
exactly. About how to get people off of them.
Yeah.
Really, is like, how do we
Yeah.
stop hormones? And so I think going to somebody who's been trained in it is really important. Because they're gonna know all the literature, they're gonna know all the newest techniques, those reference ranges that
Mm-hmm.
aren't gonna be listed on the labs themselves. They're gonna really be able to like dive into that a bit better, and probably give you a more comprehensive approach. And when they do prescribe something, know if you're getting a side effect, what it's from.
Absolutely.
I've had a lot of patients say like, "Oh, my primary started me on this, but I like felt this immediately, and so I stopped it." And I'm like, "Yeah, well, they chose the wrong dose,
Mm-hmm.
and unfortunately ruined you on that.
Yep.
Had they started you here, you would have had a much different experience, and maybe would have got there." And
Yeah.
it's just understanding that.
Absolutely. Yeah. Do we try to minimize the side effects? Absolutely. But again, everybody's going to be a little bit different. I guess what I like to tell my patients is that, month 1, 2, 3, we should be heading in the right direction. Might have to work on some things and, adjust here, adjust that. But I want 6, 12, 18 months from now to be a lot better. And we will get there. There's just going to be maybe some things we got to work on. But yeah, I like what you said about the side effects. If we get those, if we get a message from a patient saying, "Hey, I'm having this or that," most of the time we know how to handle it.
Yeah.
And provide reassurance like, "Hey, we probably don't need to stop. We don't need to completely throw this out and kind of redo, our treatment plan. We might just have to tweak it a little bit, whether that's going up or going down on a dose or, I don't know. There's just a lot of different ways we can approach it. But just seeing a provider who's comfortable with that makes a big difference
Yeah.
to help, again, minimize the side effect and all the headaches and cost and time and effort that could be associated with that is a big deal. It's a really big deal.
There are like, obviously people out there who are going to take like all these like natural herbs and supplements and things like that. And I don't want to say that that's the wrong approach, because I think that that can be powerful for some people. And I mean, that's what we're deriving supplements from,
Hmm.
right? Is like things like that too. But I definitely think like with caution, right? On some of those things, a lot of things that supplement wise that can affect our hormones can also affect a lot of other things and blood thickness and thinness and cardiovascular risk and interactions with other medications, like your antidepressants and things like
Hmm.
that. So I think getting some guidance there, even if you're like kind of hesitant on the actual hormones, but um, want more of a natural approach, like we're still there for you. We're still going to
Absolutely.
help you with that. We're
Hmm.
still going to give you the right recommendations and still know what to monitor, because just because it's a supplement doesn't mean we don't do labs.
Yeah.
We don't check things.
Yeah.
So I think that, those do-it-yourselfers out there, just be cautious.
Hmm.
Know that
Hmm.
there's still some risk, and not everybody's a candidate for certain hormones, and it goes the same thing with certain supplements too.
Yeah, I agree with that. Yeah. Yeah, we're definitely not against supplements at all. Again, if somebody is
Yeah.
coming in and maybe their numbers do look pretty good, but they're
Hmm.
just having a couple areas they want to improve, and they're just maybe not at a point in their life where they want to go down the full HRT route, I
Hmm.
am A-okay with that.
Yeah.
We're still going to have the discussion about, why and when we use
Hmm.
HRT, just simply what are the hormones for.
Hmm.
But then yeah, if they want to go down a more natural supplement route and kind of be hands off for a little bit, I am A-okay with that.
Yeah, I had a gal. She's is actually fertility is why she came in. She's an older female. She's in her 40s, early 40s, wanting to get pregnant. Was worked up by her GYN, kind of did some fertility things. Her FSH was really high, and for patients out there, like when we're looking at your FSH, the higher that number, the more it can kind of steer us towards like you're kind of getting through, menopause, or kind of gives us an idea of kind of where you're at in that whole scheme of things. And she was not in a good place. She was like in the 80s. And so, fertility for her was just really looking kind of negative. And for somebody who's wanting to potentially get pregnant, that's a very different approach on hormones,
Mm,
right? Like, we're not going to start testosterone, we're not going to start a lot of things. But for her, it was really like understanding her cycle, understanding her like LH surges and her ovulation and when her FSH is surging and those kinds of things. But we purely just did a little bit of work with her progesterone. And I started her on several different supplements to help with ovulation, very strategically, and also supplements from very reputable
yeah,
sources that are clinically strength.
yeah,
You need like almost like a provider's permission to get certain supplements, right? Because they're so strong. And we were able to, over the course of like 6 months, slowly but surely drop her FSH, and now it's like
mm,
4.2. And she's ovulating on time and things like that. And so supplements can be extremely
yeah,
powerful. So you never want to discount that,
yeah.
but they
But
need to be, monitored appropriately for
hmm
sure.
a question I get quite a bit is like when will I start to feel a difference or an improvement, or just kind of giving people
Mm,
or people just want to know a timeline, I
yeah.
guess, and understandable because again, this is probably going on for years.
Right.
They want to feel better as quick as they can,
Hmm.
which is
It's
understandable.
definitely different for everybody, right?
Hmm.
Every single person is going to have a different story. Certain hormones are also going to work a little bit faster. If I gave someone a progesterone that night, they're probably
Hmm.
going to notice difference in their sleep instantly. Like progesterone's going to help with other things too, their mood and their anxiety and cycles and things like that. But like it really can help with their sleep. And so something like that, you can have a quicker expectation. Something like testosterone, it's going to be a second.
Hmm.
It's going to be maybe a week, maybe a couple weeks, maybe a month, kind of
Absolutely.
depending on the dose and the form. Same with estrogen. It kind of just depends. So, and for men, same thing. So yeah, it's hard. And also like what symptom are you looking for improvement on? So
Yeah.
is it your energy? Is it your libido? Is it those things? That's definitely going to have a different timeline than weight loss,
Yeah.
metabolism.
Yeah.
And so really it's like setting the appropriate expectation in office with them, I think is really important. And not thinking like as soon as I swallow this pill or inject this, syringe of medication, I'm gonna feel amazing.
Hmm.
It's not always gonna be that simple.
Hmm.
but the end game will be worth it.
Absolutely. The conference I was at recently, one of the speakers said something just beautiful. He kind of asked the question, do we get old and lose our hormones, or do we lose our hormones and then get old? And I mean, I think the answer is pretty clear.
Yeah.
And that, the losing of the hormones oftentimes is gradual, and you don't realize it. Kind of, months go by, years go by potentially, but then all of a sudden it's like, what happened? Where did these symptoms come from? And again, we can help prevent that. We can help potentially slow that decline, or just simply get them back to where we want to, where they want to be.
Right.
I don't know. I just thought that summed it up beautifully in a very easy to understand concept.
Well, we could literally go on probably for another couple of hours on this and get into the weeds. But I think the takeaway is, like, if you're curious about your hormones, please just come see us, chat with us. We can do labs. There's no pressure ever. If you don't live here, we can help guide you to maybe somebody who does something similar to us. There's a lot of us out there.
Yeah.
We're definitely not like the diamond in the rough in this case. I mean, there's a lot of really great, very educated people out there trained in this realm of medicine. So yeah, feeling good it's not a luxury. It's your baseline. You can get there. Anybody can.
Definitely.
So.
It feels good to feel good. We just want to shoot for that.
Yeah.
Absolutely.